All right, so I have a couple cases for you on this video. Actually, I have three of them. I didn't put the third one on here because I'm a moron. We got a 55-year-old female with shortness of breath and a 51-year-old male with shortness of breath. The first case comes to us from Dr. Ryan Ballard, who's one of our first years. And I looked it up, and Ballard means a bald-headed man, or a strong/bold man. I've known Ryan for a couple months now. He's definitely not bold. My contention is that he's wearing a wig. Like, he's actually bald and he's got a wig on. I've never touched his scalp. I've never seen him swim. If anyone has, let me know, but I'm pretty sure he's bald. All right, so here's the pretest probability for our EKG. 55-year-old female with a past medical history of iron-deficient anemia, asthma, intestinal malabsorption, and neurofibromatosis 1, presented ED for progressively worsening dyspnea on exertion and fatigue over the past week. Patient notes she had similar symptoms in the past related to her ongoing severe iron deficiency anemia. However, she states that her symptoms feel worse than typical. Patient notices that she became short of breath walking short distances, which is unusual for her. Additionally, patient reports associated chest heaviness and intermittent retrosternal burning sensation that is non-radiating, and occasional dizziness and nausea with position change. Otherwise, patient has any fevers, chills, cough, sore throat, abdominal pain, vomiting, numbness, tingling, or weakness of the extremities. Patient's been having ongoing symptoms and notified her hematologist, who found the patient to be anemic with a hemoglobin of 6.6 and proceeded with an IV iron infusion yesterday without improvement of symptoms. All right, so the value of any EKG depends on your pretest probability. The pretest probability here is kind of concerning, right? Like, she gets chest pressure when she exerts herself. I mean, it's non-rating and stuff like that, but it is concerning. Thing to note from this history is her history of anemia. All right, here's her previous EKG. Again, this is just to establish a baseline. Pause it, look it over it, think about your interpretations and your findings are. So overall, I don't see anything too crazy on this EKG. There is normal sinus rhythm with 1P for every QRS on the rhythm strip. The axis is normal. The intervals are normal. For the ST waves, I do see some non-specific ST wave abnormalities. Like, there is this non-specific scooping here in 2-3 and AVF of these T waves. Like, see this scooping and flattening, and it's kind of like underneath the baseline. But there's no real J-point deviation. Right over in V2, like the J-points lining up. V1, we do have an upright T wave that's bigger than V6, which can be abnormal in the proper clinical setting, but again, this is just a baseline EKG. Again, this non-specific repolarization abnormalities, but again, nothing conclusive. So my overall interpretation, this is non-diagnostic, and remember, this is just to establish a baseline. Now, here's the EKG when Dr. Ballard saw her. Same thing. Pause. Write down your findings and think about what your interpretation is. All right, so let's go through it together. First off, I do see signs of sinus tachycardia. Okay, down here in the rhythm strip, which is lead 2, we do have 1P for every QRS. The rate's a little fast, so sinus tachycardia. For access, it's up in 1 and up in AVF, so normal. For intervals, I do not see any prolongation of the T wave, as it does not fall between halfway of each R wave. Well, I take it back. Maybe there is a little bit of prolongation of the QT. Okay, I would defer to what the machine has to say for that. I do not see widening of the QRS. I do see some signs of atrial abnormalities with this biphasic P wave in V1 and V2, which can be a sign of a left atrial enlargement. The main thing for this one is the ST wave segments. Now, when we go through here, we see repolarization abnormalities in almost every lead. Okay, let's start in the precordials. Right here is where the PR segment is. Right here is where the J point is. We do have maybe 1.5 millimeters of elevation with this linearity of the ST segment. Okay, we do have slight J point deviation, lead 2, maybe 0.5 millimeter. More significant J point deviation in V3, maybe 3 to 4 millimeters. Same thing over here in V4, 5, and 6. You can see that the J point is below the PR segment in all of these leads. Okay. Not only do we have this depression, but again, we have linearity of the ST segment. Sorry, let me back up. You can also see this J-point deviation in many other leads. Look up here at AVR, okay? There's the PR segment. There's the J-point, maybe 1 millimeter of elevation. Similar issues over here. Right here in lead 1, There is the PR segment. There is the J point, which is depressed from the PR segment. Same issues in 2, 3, and AVF. Okay. The other thing to note is the morphology of these ST wave segments. Look over here in V3. See how linear this ST segment is. Look over here at AVF. Look how linear this ST segment is. Not only is it linear, but it's downsloping, which is also concerning. Same issues over here in lead 3. And again, same issue over here in V4, 5, and 6. Not only is there J-point depression, but there is downsloping ST wave segments. All of these are abnormal. So my overall interpretation is sinus tachycardia with diffuse repolarization anomalies, which can be a sign of infarction or ischemia. So the question is, what do you do? Okay. When we go back to the history and the pretest probability, this patient is coming with gradual onset of symptoms that are worse with exertion. What we have here is multiple J-point deviation and repolarization abnormalities. In fact, we have a global reperfusion abnormality. Like with the exception of AVL, every lead either has J-point deviation or abnormal appearance of the ST waves. Okay. For this case, this is my opinion and my experience I've come over the years of practice. For me, when someone is sick and you have a diffuse repolarization abnormality, i.e. a repolarization abnormality in every lead, it's usually one of 4 things. Okay. The first one is coronary artery disease. Okay. And when we're talking about coronary artery disease, we have to distinguish between the 2 subtypes of pathology. Number 1 is a type 1 infarct, which is an occlusion, right? The second one is a type 2 infarct, which is a mismatch, okay? For a type 1, it means there's an actual occlusion of the vessel that needs to be open. For a type 2, the vessels are not occluded. There's just some process that's causing a lack of blood supply to the heart, be it anemia or hypotensive in the setting of sepsis or shock. Okay. Number 2 is metabolic. Okay. Specifically, elevated potassium or low pH. Okay. Number 3, let me get rid of this. Number 3 is tox. Okay. And that's any drug, be it prescription or recreational drugs that affects the propagation of electricity through the heart, such as antipsychotics, antidepressants, antihistamines, Benadryl, DIG, amiodarone, propafenone, all of those things. Anything that affects those levels can be a sign of a global repolarization abnormality. And number 4, which is usually less of the case, is brain problems. Okay, people who have significant brain issues, be it traumatic brain injury, hemorrhagic infarct, ischemic infarct. The severity of that pathology, in my opinion, affects connexin 43, which helps propagate electricity through the heart, and that's why you get those repolarization abnormalities in brain problems. All right. So Dr. Ballard, being the astute physician that he was highly suspicious that this person's abnormalities was from lack of blood supply due to anemia and not acute infarction, and that's what happened. All right. As we stated in the history, her hemoglobin was 6.6. When he checked it, it was only 3.6. Yes, her troponins were elevated, but again, this is more of a demand problem, not an acute occlusion. So the teaching point for this one was these diffuse repolarization abnormalities in someone who is sick and has symptoms. Think about coronary artery disease, and you have to differentiate between a type 1 or a type 2 infarct. Type 1 is an acute occlusion that has to go to the cath lab. Type 2, there is a mismatch. And you fix that problem by fixing the underlying condition. Just to highlight this issue again, this is a case that I went over last video with Dr. Hartle. This is a gentleman that came in with chest pain. I neglected to mention this in my last one, but this is also a case of a diffuse repolarization abnormality, correct? Like when we look through here, in every lead, there's a repolarization abnormality. Up here in 1, there's J-point deviation and linearity of the ST segment. Same issue in 2. J-point deviation and linearity, same in 3. I mean, it's slight, only 0.5 millimeter, but there is J-point deviation. And look at this linearity, especially compared to the amplitude of the QRS. Same issue in AVR. There's the PR segment, there's the J-point. We have some elevation with this abnormal appearance and or linearity of the ST segment. Same in AVL, okay? J-point deviation, linearity, maybe not so much in AVF, but same issues here in the precordium, correct? Look at this J-point deviation with linearity up in V1. Look at this J-point deviation in V2. Look at this J-point deviation in 3, same thing, V4, 5, and 6, all right? Not only is there J-point deviation, but there's also linearity of the ST segments. And again, this global reprovision abnormality turned out to be from an acute occlusion of the coronary arteries. If you need a reminder, go back to that previous case. All right, here is another case. Initial evaluation done by Dr. Bruss at 0640. 51-year-old male to the ED for chief complaint of shortness of breath. States that the symptoms started last night, but have been lasting for a couple months now. States that he has a hard time breathing when he falls asleep, thinking he is having panic attacks. States the symptoms are intermittent. States that he have a history of sleep apnea. States that he coughs, but not coughing up phlegm, and used to be a smoker. Denies COPD, diabetes, using inhaler, or wheezing. So I have more information, because this is actually my case. So the guy looked fine. He comes in the morning, and he's like, I feel like I'm going to die. And I'm like, well, what do you mean? He's like, well, when I go to fall asleep, I just feel really bad. I get really dizzy, really short of breath, really panicky, and I feel like I'm about to die, and it goes away on its own. And I was like, do you have sleep apnea? And he's like, yeah. I was like, have you been using a machine? He's like, no, the mask is broken. I'm like, well, that's probably what it is, but let me work you up and see what happens. Okay. Here is his previous EKG. Again, this is just to establish the baseline. Same thing, I recommend pausing your computer, going through the EKG, and letting me know what your interpretation and findings are. So overall, nothing too crazy. Okay, when we look down here at the rhythm strip, which is lead 2, we do have 1 P for every QRS, so it is sinus. The rate is relatively normal, maybe a little bit slow. One thing to note, when we do look at this rhythm strip, we do see 2 different P wave morphologies with 2 different P to P intervals, correct? We have this 1 P wave morphology right here, which is kind of smoothed and humped. And then we have this other one, which is wider and notched. Again, that's consistent with an ectopic atrial pacemaker or a wandering atrial pacemaker, most likely from underlying conditions that affect the lungs. For this guy, it's probably his sleep apnea and or smoking. Remember the difference between wandering atrial pacemaker and multifocal atrial tachycardia is that for MAT has to be tachycardic and have more than 2 different P wave morphologies. I do think the axis is borderline left. I mean, it's up in 1, maybe down in lead AVF, so more left than anything else. For the intervals, I do not see any prolongation of the QT, C, or QRS. For the ST waves, I do see some non-specific ST wave abnormalities. Specifically to note this T wave in lead 3. I mean, look at that. Like, that T wave is bigger than the QRS is. In the proper clinical setting, that could be a hyperacute T wave. I mean, same issue down here in lead AVF, right? Like, this T wave is not crazy big, but it's over half the amplitude of the QRS. That's kind of concerning in the proper clinical setting. He does have relatively large R waves in the precordial leads, which can be a sign of pulmonary hypertension or right ventricular hypertrophy or right ventricular strain. These R waves accompanied with these P wave abnormalities does make me suspicious for the possibility of underlying valvular issues. Again, all of these findings are non-specific and non-diagnostic, especially when this is just a screening EKG. So here's the EKG I have when I saw him. Same thing, pause, put down your interpretations and think about, or your findings and think about what your interpretation is. Okay, so first off, what I see is sinus bradycardia. Okay, we have 1 P for every QRS down here in the rhythm strip. We're sinus, we're done, let's move on. For the intervals, it's up in lead 1, equivalent in AVF, normal to left axis deviation. Again, left axis deviation, I don't really care much about. I care more about a right axis deviation. For intervals, again, I see no prolongation of the QTC or widening of the QRS. Interestingly, no, he does have a pretty good looking U wave down here, which he didn't have before, which is interesting. We'll talk about that later. For the ST segments, again, I see nothing completely diagnostic, but I do see repolarization abnormalities. Okay, number 1, I hope what catches your eye after the last one is this inversion in AVL. Okay, remember in the proper clinical setting that can be a sign of coronary artery disease, but remember this guy comes in not with any chest pain. Okay, again, we do have this non-specific T wave abnormalities in 2-3 AVF, specifically hyperacute T waves. Like, look at these. Like this T wave, like this entire QRS can fit underneath that T wave. Same issue here. Same issue here. Look, that whole thing can fit underneath there. Again, focal hyperacute T waves, and also we have these focal U waves. Again, those can be concerning for coronary disease in the proper clinical setting. We have these same issues over here in V4, 5, and 6. You can see this U wave, which you didn't really see before. I don't see real significant J-point deviation in the precordial leads or hyperacute T waves in the precordial leads. So overall, again, my overall interpretation is this is non-specific. In the proper clinical setting, this could be concerning for an early infarct with the inversion in AVL and these hyperacute T waves in 2-3 in AVF. Okay. But again, I don't treat an EKG. I treat a patient. He wasn't having any chest pain. So I'm like, all right, let me work you up, see what the troponins and everything else show. While he was in the emergency room, he pushes his button. He's like, hey, it's happening right now. I feel like I'm going to die. Okay, repeat the EKG, and here's what we have. Again, pause your computer, take a look through it, and see what you think. The most relevant thing here, or blaring thing here, is this very bradycardic rhythm. Okay. Now again, they call the rhythm strip for a reason, and it's always either lead 2 or V2 because it's the best place to see P waves, and we read this just like a book, from left to right. P, QRS, T, no other P's. P, QRS, T, P, QRS, T, P, QRS, T, P, QRS, T, P, QRS. So it's sinus brady, like there's no blocks here. Okay, this is not an AV nodal block, nothing like that. It's sinus bradycardia. Okay, so for this gentleman, with his rate changing and him being in sinus, I want you to think about what your diagnosis would be. Okay, now the first thing I did was think about reversible causes. Well, let me back up. So anytime you have a bradycardic rhythm, the first question is the patient stable or unstable? While he had these bradycardic episodes, he was maintaining fine and his pressure was okay, but he was pretty symptomatic. So I would give him like 0.5 milligram of atropine, which should help with his rate and with his symptoms. When someone is bradycardic and extremely, unstable, you reach for a pacer, which this guy doesn't need. The other thing in my mind was I was thinking about reversible causes. Specifically, when you see a bradycardic rhythm, you want to worry about hyperkalemia and or medications that he may be taking, like calcium channel blockers and beta blockers. The only medication he takes is aspirin and methadone. Okay, his troponins were normal, white count was normal, potassium was normal, drug screen was only positive for methadone, everything else was fine. So this was a case of sick sinus syndrome. Okay, I spoke with the cardiologist, who's like, "Yep, I agree." He took him to the cath lab, put a pacemaker in, and the guy actually went home like the same day. So this case, the second case is about sick sinus syndrome. Okay, sick sinus syndrome, also known as sinus node dysfunction, is a disorder of the SA node caused by impaired pacemaker function and impulse transmission, producing a constellation of abnormal rhythms. These includes atrial bradyarrhythmias, like our gentleman had, atrial tachyarrhythmias, and sometimes bradycardia alternating with tachycardia, often referred to as tachybrady syndrome. These arrhythmias may result in palpitations and tissue underperfusion, leading to fatigue, lightheadedness, pre-syncope, and syncope, which is what our gentleman had. So, I'll read more, but overall, sick sinus syndrome is a broad term that encompasses many things. The key for this is that it's a syndrome. Okay. The definition of a syndrome is any constellation of symptoms that occur together. So any constellation of symptoms can be classified as a syndrome. Like I have this weird syndrome where like if I don't sleep, like I get these symptoms, like I get cranky, my eyes are dry, like I get palpitations and I get like nauseous and stuff. But if I sleep, it gets better. Like I call it cyclic sleepy syndrome. Like there's no cure, it's terminal, I'm stage 5. Just give up on me. The etiologic factors leading to sinus node dysfunction can be classified in 2 categories. Intrinsic pathology of the sinus node itself, typically resulting from fibrosis of the nodal tissue and external causes that affect the SA function. I'll let you guys just read the rest of it. If you want to look at the full paper, I left the website here. Key mechanism and risk factors, dose-dependent effect. So that's what I was talking about. So the gentleman was on methadone. Methadone can cause bradycardia. Okay, for the following reasons. Bradycardia is more commonly observed with higher doses of methadone. It has a verapamil-like structure, so it works like a calcium channel blocker. increased vagal tone, drug interactions, and pre-existing conditions. Here's an illustration from this paper as far as how methadone affects your heart. Okay, methadone is known to cause QT prolongation and torsades. We see lots of patients with methadone and they have underlying issues. Always keep that in mind when you're thinking about treating these patients with medications in the emergency room, right? We use so many medications like Zofran, Haldol, azithromycin, all these things that can prolong the QT. If someone's on methadone, at least think about checking what their QT is before you give them medications. Oops, sorry. So that gentleman, the whole case was this really sick sinus syndrome or was this from his methadone? It's impossible for us to tell. And the electrophysiologist was on the same page. He's like, well, I'm not going to stop his methadone, so I'll just put a pacemaker in. So was this truly sick sinus syndrome or was it from his methadone? Impossible to tell, but regardless, the treatment and the outcome was the same. I got another case for you. This case is just from today. Altered mental status. Dr. Bruss, 918 AM, 75-year-old female presents for altered mental state. She cannot say her name, and history was given by EMS. States she has a steady decline over the past few days. So this is a nursing home patient that came in today. Over 3 to 4 days, she's been slowly getting worse than usual. She can no longer ambulate without assistance. She's confused and lethargic. On exam, she was awake and alert. She was slightly confused, but she wasn't horribly toxic appearance. And she was also tachycardic, hypotensive, and hypothermic. Okay? All right. So remember, the value of any EKG depends on your pretest probability. The pretest probability for this patient is kind of crappy because she can't tell me anything. She can't tell me she's got chest pain. She can't tell me what's going on, so it's hard to tell. So here's a previous EKG. Again, this is just to establish a baseline. As a practice, I recommend pausing your EKG, writing down your findings, and think about what your interpretation is. So here's my interpretation. Overall, we have 1P for every QRS. We have a normal sinus rhythm. There is slight signs of atrial enlargement with this enlarged P waves in 2-3 and AVF with this notch in here. There's also a biphasic P wave in V1, which is highly suggestive of left atrial enlargement. Okay, it is up in lead 1 and up in AVF, so the axis is normal. For the intervals, I do not see any prolongation of the QTC, as it does not fall between halfway between each QRS, and the QRS is nice and narrow. For ST wave segments, I do see non-specific repolarization abnormalities. There's some flattening over here in AVF and maybe 0.5 millimeter of J-point deviation. Same issue over here in lead 3. This T wave is flat and or inverted. There is a large Q wave as well. Let's see. I don't see any significant J-point deviation in these precordial leads. This could be concerning for a hyperacute T wave, but again, that depends on your pretest probability. This is all wonky and stuff over here, but again, I see nothing definitive. So my overall interpretation, once again, this is a non-diagnostic, non-specific EKG with some suggestive signs of atrial enlargement and or underlying structural heart disease. So again, that's just the previous EKG. Here's the EKG when I saw her. Same issue. Pause, evaluate, and interpretate. All right, so what do we got? Number 1, looking at the rhythm strip, we have 1P for every QRS, and the rate's a little bit fast, so we have sinus tachycardia. For the axis, it's up in 1 and up in AVF, so normal. For the intervals, again, I don't have the machine numbers here, but there may be slight prolongation of the QTC, but I would defer to the machine for that. And I do not see any widening. The QRS looks nice and narrow to me. Now let's go over the ST wave segments. We have multiple abnormalities here, okay? Starting in lead 1, we do have J-point deviation, okay? It's tough to see, but when we look, there's the PR segment, there's the J-point, maybe a 0.5 to 1 millimeter of J-point deviation. Same issues here in lead 3, okay? There's the J-point, there's the PR segment, maybe 1 to 2 millimeters of J-point deviation in lead 3, lead 2. Same thing over here in AVF. There's the PR segment. There's the J point. Same issues down here in AVF. There's the J point. There's the PR segment. There's the J point. We do have elevation. We have, depression in lead 1. The J point is right there. The PR segment's right there. The J point's right there. We have 1 millimeter of depression. Same issues in V2. Okay, depression, as well as a more concerning hyperacute T wave in there. In V3, we have J point elevation. There's the J point. There's the PR segment. Same issues over here in V4, 5, and 6. Okay. The J point is deviated from the PR segment in all of these leads. Once again, this EKG highlights why, always comparing the J point to the PR segment, because if you look over here in lead 2, like the TP interval kind of lines up with the J point, so there's no real like J point deviation from the QT segment. And same thing over here in these lateral leads, right? Like there's the TP segment. When we follow it out, it goes to the J point. We also have PR depression in AVR. There's the PR segment. There's the J point. And we also have this flattening of the ST segment in AVL. There's no real J point deviation in AVL. So my overall interpretation is this is sinus tachycardia with diffuse repolarization abnormalities, including J point deviation, prolongation of the QTC, which could be concerning for infarction, ischemia, and or pericarditis/myocarditis. So if you notice, this is another case of a diffuse repolarization abnormality. Like we have a repolarization abnormality in literally every lead, okay? So like we talked about before, those are the 4 things to consider: coronary artery disease, toxic, metabolic, or brain issues. For this patient, based on her pre-test probability, coronary artery disease, it's not as likely. She's not complaining of chest pain. Toxic, again, not as likely because she's not taking any recreational drugs. Is she toxic from prescription drugs she takes from renal failure? Something to consider. Metabolic, for me, that was the main issue. I thought this was going to be a metabolic process. We've been going on for 4 days, hypotensive, tachycardic, hypothermic. I was worried about hyperkalemia with renal failure and or acidosis. And again, brain is another thing to consider for this patient, but she had no focal neurologic deficit, so less likely to be a focal brain issue. This case was also interesting because it highlights I can never win with cardiology. Like, when I call cardiology, I'm like, hey, this person needs to go to the cath lab. They're like, nah, I don't think so. When I call them like, hey, I don't think this person needs a cath, they're like, no, we're going to cath them. So that was my thought process for this patient. I thought it was more likely a metabolic process causing these EKG abnormalities. She was super sick. I don't think like an emergent cath was indicated, but I documented all this, and I said I was going to talk to cardiology as well. Because for me in my practice, that's what I do for these sick patients with abnormal EKGs. Number 1, if they're sick enough, I call a STEMI. Number 2, if I'm not going to call a STEMI, I immediately get the cardiologist on the phone for consultation. Because you get the ball rolling right away and you talk to them before any labs or troponins are back. You say, hey, I have this patient with this EKG. This is what I think is going on. What do you think and what do you recommend? And then you document that, and that helps you out medically, legally, as well as it's good care for the patient. So cardiology came down, saw the patient. He's like, yeah, I think she's sick, but I'm going to take her to the cath lab. And I was like, all right. So here's what happened on her labs. Her troponin, 3,669. Okay. Her cath was clean. Normal coronary arteries, 55% ejection fraction, continued risk factor modification. And if you'll notice, she was acidotic. Okay. She had a pH of 7.17. So for this case, the teaching point is, again, this is a global repolarization abnormality. When you see that in someone who is sick, think 4 things: coronary artery disease, toxic issues, metabolic issues, or brain issues. For coronary artery disease, you have to distinguish between a type 1 and a type 2 infarct, as the treatment is totally different. For toxic, it's any drug that affects the propagation of electricity through the heart, things that affect sodium channels, potassium rectifier channels, and or connexin 43, like antipsychotics, antidepressants, street drugs, Benadryl, all of those things. Number 3, for metabolic issues, it's usually either hyperkalemia or acidosis, as we saw in this case. And number 4, in my experience, is less likely is significant brain issues. And again, like for that, it's less likely to cause these repolarization abnormalities. I have seen it, but those people are all like super sick. Like they have like focal deficits, low GCSs, things like that. All right, that's all I have for this case. Remember the things that we talk about all the time. For many of these cases, it wasn't, you don't treat the EKG, you treat the patient. The value of the EKG depends on your pretest probability. And the main thing was the global repolarization abnormalities. Think of those 4 things in your workup. That's all I got. Ballard's wearing a wig. Peace, I'm out.